Good day and welcome to today's presentation. Please note this webinar is being recorded. All participants are in a listen-only mode. If you would like to ask a question, please enter it into the Q&A panel located at the bottom of your screen. It is now my pleasure to turn the call over to Lisa Sullivan. Please go ahead.
Thank you. Good afternoon, everyone. My name is Lisa Sullivan, and I am looking forward to a wonderful event today. Welcome to the National CMS CDC Nursing Home COVID Training Curriculum, a series of national nursing home training sessions that are geared specifically to the pandemic. This training will allow nursing homes to receive recognition certificates for attending. In addition, in the future, we will have downloadable achievement badges made available for those who attend. Please remember to enter your CMS certification number, or CCN, when registering for future events so your nursing home gets credit and you earn the badges. Thank you for taking the time to be here with us today, and a special thanks as well to our CDC colleagues for partnering with us on this important training series. A few reminders before we get started. The slides and resources can be found on the QIO program website, and the recording from today's event will also be posted there within a week, so please be on the lookout. During the open discussion period, please keep in mind that we will get to as many questions and comments as time permits, but if there are any unanswered, we will address those post-event, and they will be included on the QIO program website once finalized. Next slide, please. It is my pleasure to introduce our first speaker today, Linda Behan, the Senior Director of Infection Prevention and Control for Genesis Healthcare. Linda Behan is the Corporate Senior Director of Infection Prevention and Control for Genesis Healthcare. Genesis is one of the largest post-acute care providers in the country, with more than 400 skilled nursing centers and assisted senior living communities. She currently serves on the APIC Professional Development Committee. Linda has been certified in infection prevention and control for over 11 years. She leads a team of infection preventionists in developing policies and procedures, as well as developing and delivering education across the company. Linda has spoken at APIC annual conferences on antibiotic stewardship and a novel technology to reduce UTIs and incontinence-associated dermatitis. She frequently speaks on infection prevention and control topics at state healthcare and other professional associations. She has served on the technical expert panel entitled the Comprehensive Unit-Based Safety Program, CUST, for Antibiotic Stewardship. Linda is also a member of the faculty for AHCA's Infection Preventionist Specialized Training, contributing the modules on antibiotic stewardship in nursing homes and water management plans. Linda, the virtual floor is now yours.
Thank you, Lisa. Good afternoon, everyone. I'm happy to be here with you today to discuss accessing current regulations and guidance, as well as outcome and process surveillance. CMS provides a variety of resources for facilities. CMS memorandums explain new or updated expectations of providers and a list of resources available. Stakeholder calls are intended to provide updates, share best practices among peers, and offer attendees an opportunity to ask questions of CMS and other subject matter experts. For nursing homes, these are held twice a month on Wednesdays at 4:30 p.m. Eastern Standard Time. The toolkit is a web page which contains information on CMS and HHS materials available on COVID-19 and links to the recordings and transcripts of the stakeholder meetings. Next slide, please. The CDC has web pages devoted to many aspects of COVID-19, and some of the pages are dedicated to nursing homes. Now, information, regardless of the source, isn't useful if it isn't accessed, and it doesn't become powerful and empower your staff unless it's shared. Designated persons in the center, it could be the center leadership and the infection preventionist, should build regular attendance at these calls or accessing the sites into their daily workflow. Schedule yourself to look at the websites weekly or whatever frequency works for you just as you would schedule any meeting. Once you have information, how is this information disseminated among other center leaders and staff? Morning stand-up meetings with department heads can be used to discuss this information in more detail, decide follow-up actions related to the directives or guidance, and how to monitor compliance. For huddles on units, provide a brief description of guidance, and very important, explain the whys or rationale behind the guidance. Tell staff that you're developing a policy or procedure and training and when they are to be expected. Create bookmarks for web pages. Sign up for emails from the CDC when pages are updated. And create shortcuts on your desktop. Anything to make it easier for you to find what you need and to do your job. Finally, all skilled nursing facilities are required to report their COVID-19 data to NHSN at least weekly. Angela Anttila will be speaking to you more about that. Next slide, please. Surveillance is vital to any infection prevention and control program year-round. During this pandemic, a facility can't protect against the virus entering the center unless they're sure there are no leaks in the ship, meaning, are all the measures the facility put in place consistently being followed? For example, with employee screening, on the night shift, how tight is that process? Are people just letting others in? Validate the screening documents to see how complete they are and if everyone is being captured. If a patient demonstrates respiratory signs and symptoms, are we suspicious of COVID versus influenza? Or what about a non-respiratory cause, such as CHF or COPD exacerbation? How are you aware of those symptoms on an existing resident or a new admission? While a diagnosis is being made, the resident should immediately be placed on precautions to protect others from the spread of that infection. Did it occur? Do you see staff becoming symptomatic or testing positive, especially now with so many areas of the country having a reemergence of cases? Who did that staff member come into contact with? Put follow-up measures into place. If a resident tests positive for COVID, perform root cause analysis to determine how that infection was transmitted. Were staff wearing masks below their nose? Is inconsistent hand hygiene being performed? Has staff or equipment from a COVID positive unit been floated over onto a naive unit? Perform trending to see clusters or movement of the virus in the center. Have a systematic process to follow to ensure consistent data is obtained, and plan out your data collection activities and staff observations. Next slide, please. This is an example of a screening tool completed by nurses on different shifts. It captures the vital signs and symptoms that are suggestive of COVID-19. Explore having it built into your EHR so that it automatically schedules, and then you can track that they were done. The IP can run a report daily showing which residents triggered indicators on the screen and compare it to the line list to ensure everyone is accounted for and the correct information was documented. This can also be done on paper. Consider a spreadsheet with each of the residents' name and indicators that the nurses mark off. The spreadsheets then can be easily viewed by the facility IP. Of course, if indicators are present, the nurse needs to document the change in the resident's condition and report to the medical provider. If indicators are present, Implement the use of appropriate PPE and cohorting. Using tools such as these helps the IP avoid having to read through 24-hour reports looking for new cases. To keep abreast of the changes in resident status, the IP should attend daily clinical meetings or unit huddles. By readily having this information, the IP can then easily follow up that proper PPE is being utilized, the resident has been cohorted properly, and reinforce with just-in-time training the infection prevention and control measures that need to be followed. Next slide, please. Next is the all-important line list. Line list should include not only symptoms, but also COVID and IgG and IgM testing results and precautions in use. Having this information in a line makes it easy to determine how many days since the onset of symptoms, days since last fever, improvement in symptoms, and have specific comments available. A spreadsheet can be used not only to capture data, but also make interpretation of the data easier. You can see on this spreadsheet, different color codes were programmed in to display resident case status, positive, negative, suspected, or presumed. Your line list should tell the person's story. So the beginning, how did they get on the list? Did they have symptoms or a positive screening test? Were they admitted to your center already positive? Then you have the action-packed middle, such as different tests that were done and their results. What precautions were implemented? Were there any hospitalizations? And finally, the end of the story. Did you use strategies to discontinue precautions? Were there a transfer to a hospital with no return, a discharge, or a death? It can be a one-stop shop for the IP. At the bottom are various tabs for not only resident and staff line listings, but also instructions for use of the tool, definitions of terms, and the outbreak management program. The center team should review the line list daily and discuss persons on the list to monitor symptoms, test scheduling and results, and work towards resolving the episode through the use of one of the strategies to discontinue transmission-based precautions. Next slide, please. Your line list may also be electronic through your EHR or other system. It's a good idea to manage your resident and staff screenings on a separate document from your active line list. If persons are negative and asymptomatic, there's nothing to manage and just makes the line list more cumbersome to work with. This can be accomplished with a spreadsheet also. By watching, especially in color, testing results, the center can determine how often testing needs to be done. Weekly, if still getting positive results, or when there's a decline in positive cases or no more positive cases, you can move to less often, like every 2 weeks or more, but take into consideration community prevalence. Of importance is having a validation process to ensure the integrity of the information on the line list, as so many decisions are made based on that information. Have a daily process where 2 people review all the changes within the past 24 hours to be sure they're correctly reflected on the tool. Next slide, please. Besides using their traditional paper floor plan that the IPs color in, think outside the box. Consider using PowerPoint. Create a universal legend and place the facility's floor plan onto the PowerPoint slide. Large centers may need 1 floor per slide. The symbols and colors can then easily be applied. Each day, the slide is copied and pasted onto a new slide and updated. It can be fascinating to flip through the slides and watch the movement and resolution of an outbreak in the facility. Keeping the heat map updated and integrating it into a daily review of your center's outbreak status can really point out areas of leakage in the ship. You can see new positive cases on a unit that was previously naive, and it will assist with cohorting decisions. The heat map will readily reveal that a positive resident may still be in the room with a negative or suspected resident, which is inappropriate. The heat map will quickly show available proper rooms for that resident's placement, or, if necessary, common areas that can be temporarily used. Next slide, please. Finally, you can't talk about surveillance without mentioning process surveillance. The key to defending the center against an outbreak and then quickly and effectively managing it depends heavily on all staff complying with the infection prevention and control measures your facility has put into place. Have a tool which gets scored. The scoring allows consistent measurement with staff compliance and will reveal progress towards improvement. Now, the tool cannot be too long to be impossible for the center IP or the IP designees to complete, but should encompass main areas such as employee visitor screening, residents on precautions, PPE use, care of the environment, or whatever you feel is important. Review the results of daily morning meeting to act immediately on concerns and bring to QAPI for a more holistic review of the process and results and to develop a plan for long-term improvement. You know, even the best infection preventionists cannot observe all staff practices 24/7. One suggestion is to utilize IP designees for all shifts. The IP designees should be well-trained in infection prevention and control practices and competent to perform staff observations. The IP designees can provide just-in-time training as needed to staff. Engage technology. Consider using iPads, laptops, or other mobile devices to conduct virtual infection control rounds. These are unannounced and occur on all shifts, all days of the week. Center leadership and/or regional leadership will contact the center and they will direct the IP designee where to go, what they want to see. Like the employee break room. Is social distancing being maintained? Look for those masks below the nose. It's amazing what you can see and then quickly remedy. I hope I have provided you with a review, next slide please, of CMS and CDC resources and how easily to access them, as well as outcome and process surveillance with possible ideas to use in your own facilities. Thank you. Lisa, back to you.
Thank you so much, Linda. Great job. Next slide, please. It is now my pleasure to introduce our next speaker today, Angela Anttila from the CDC. Dr. Anttila is a certified infection prevention practitioner working as a nurse epidemiologist in the surveillance branch with the Centers for Disease Control and Prevention, Division of Healthcare Quality Promotion. She serves as a subject matter expert, providing consultation and technical assistance regarding surveillance and reporting of healthcare-associated infections, exposures, and outcomes, adherence to prevention practices, and antimicrobial use and resistance using the National Healthcare Safety Network's long-term care facility component. For more than 20 years, Angela has been successful at blending her patient care expertise and passion for public health. She has effectively engaged in roles of trauma nursing, infection prevention and control, research, healthcare epidemiology, academia, consulting, information technology, healthcare quality improvement, correctional medicine, and clinical excellence. She holds a Master's of Science in Nursing and a PhD in Public Health and Epidemiology. Angela, please take the floor.
Thank you, Lisa. And hi, everyone. Now that Linda has done such a great job at talking about outcomes and process surveillance tools and guidance, it is my pleasure to review with you the highlights and tips for collecting the COVID-19 data for submission to the National Healthcare Safety Work, also known as NHSN. Next slide. I want to begin by providing you with a brief description of NHSN and reporting options available within the component for those of you who may be less familiar with NHSN. NHSN is a secure internet-based surveillance system managed by the Centers for Disease Control and Prevention, also referred to as the CDC. It is the most widely used surveillance system in the U.S., used by diverse healthcare facility types such as hospitals, outpatient dialysis centers, surgery centers, and of course long-term care facilities, nursing homes, assisted livings, and so forth. These different facility types use NHSN for the systematic collection, analysis, and summarization of healthcare data, including healthcare-associated infections, antimicrobial use and resistance, adherence to prevention practices, exposures and outcomes, and much more. NHSN is developed and maintained by a diverse set of subject matter experts, such as myself, with decades of experience in public health, healthcare infection and prevention, epidemiology, healthcare informatics, and statistics. We collaborate with our local and state public health agencies, as well as professional groups and private groups, which are considered to be an operational imperative for us. As a reminder, as I go through these updates for NHSN, facilities reporting to NHSN do still need to follow the state and local public health reporting requirements. Okay, next slide, please. This slide is a little bit busy, and I will not be reading the slide to you, but I did want to just kind of show you how large NHSN really is. It is organized by components, you can see at the top, and each component is based on the type of facility participating in the application. So for the sake of time, I will focus specifically on the long-term care facility component, which consists of 4 reporting modules, as you can see in yellow. So we have the healthcare-associated infections, the laboratory-identified event, prevention process measures, and then we have our newest module, which is the COVID-19 module, which was released on April 28, 2020. And this module was developed to better understand the challenges faced by long-term care facilities during this pandemic, and to assist with identifying resource needs that will enable priorities for public health action. Next slide, please. The long-term care facility COVID-19 module has 4 reporting pathways, which I tend to think of that as surveillance options. So 4 reporting pathways / surveillance options for data collection and reporting. Each pathway consists of a combination of data elements, which include counts for surveillance, counts for surveillance during a reporting period, checkbox type selections, and then you have your yes and no type responses. Next slide, please. In this slide, the specific data elements for each pathway are shown. Data elements requiring counts are marked with an asterisk by each data element, as you can see in the green boxes. When reporting counts into the module, it is important that only new counts be reported, and this is referred to as incident counts. And I'm going to talk about this a little bit more as we progress through the slides. If you do not follow this guidance and you're not only reporting incident counts during each reporting period, then it is possible that your data could be falsely inflated and not reflecting the true burden in your facility. So I'm going to briefly go over each reporting pathway just to give you an idea here. So the first one is the resident impact and facility capacity. So you can see the different reporting elements under this pathway. This is the most robust pathway that we have. So this pathway may take a little bit longer for facilities to complete in comparison to the other three. But this pathway allows for the assessment of COVID-19 among residents as well as facility capacity and testing. And then the next pathway is the staff and personnel impact pathway. And this provides data about the impact of COVID-19 on staff working within the facility, as well as staffing shortages. And then you have the supplies and personal protective equipment pathway, which assesses the availability of supplies and personal protective equipment that is available in your facility for conventional use. An accurate assessment of supply availability is very important for supply distribution to facilities that are in need of adequate PPE or personal protective equipment. And then the last reporting pathway is the ventilator capacity and supplies pathway. And this pathway provides an estimate of mechanical ventilator availability within the long-term care facility and use of these mechanical ventilators specifically for residents with suspected and or confirmed COVID-19. Only facilities that have ventilators for their long-term care facility will need to complete the ventilator capacity and supplies pathway. And then I also just want to mention before I go to the next slide that case definitions and reporting instructions are available for each of these pathways and can be found on the long-term care facility COVID-19 webpage. And I did provide the link in, I believe, the last slide of the presentation today. Okay, we're going to go to the next slide. If you have been using our module, then you already know that you do have quite a bit of flexibility when it comes to reporting data within the NHSN module. However, there are some best practice tips that I'd like to share with you that may help with consistency and accuracy of your data. So some of these actually feed upon what Linda had spoken about in her slides, but I want to stress the importance of consistency. It is very important for you as well as for analysis for national data collection that each facility is applying consistency, and that is consistency in how the data are collected and how the data are reported. So each facility should determine how often the data will be submitted to NHSN. The CMS rule does require that data be entered at least once per week, so that's once per 7 calendar days. While some facilities enter data for every day of a surveillance week, others choose to enter data differently. So for example, we have many facilities that choose to enter their surveillance week as a total once per week, and that is okay. Either way, it is important to remember that only new counts for that surveillance week are reported into the module, meaning if a user reports counts more than once a week, each time those counts are reported, only the new counts since the last time those counts were reported to NHSN should be included. And I'm going to show you some examples again in the next slide actually. But as a reminder, data must be entered at least once per week, even if the count is 0. A blank field equals missing or incomplete data. So a 0 should be, and if there's 0 for a count, be sure to enter that 0. The next thing that you will want to do is to define what your facility considers as a surveillance week, so as well as a reporting day. So your surveillance week will be the 7-day period in which you will be calculating or adding your COVID-19 data. And then the reporting day will be that 8th day or 9th day, depending on how you're reporting, that you actually enter the data into NHSN. And that example is if you are entering just once a week. So defining your surveillance week and reporting the weekly data on the same day every week is important. You may also be able to save time by updating your facility line list, as Linda mentioned, to include the COVID-19 data elements. A good facility line list can really improve data accuracy significantly. And then you can use the data from your line list to report new counts for each surveillance week. And then lastly, again, this is a repeat from Linda, facilities are encouraged to verify the accuracy of data submission for each reporting week. NHSN does transmit submitted data to CMS every Monday morning, really early on Monday morning, which means that validation should occur no later than Sunday of each week if you choose to validate your data. Okay, we're going to go to the next slide. In this slide, I provided an example to give you an idea of how you could collect counts. So remember, Linda mentioned that you will have your daily line list of your residents. And then from that line list, you may want to develop a worksheet or another document in which you transmit or you keep just for those suspected or confirmed residents, because if you have residents that are not confirmed or suspected, then your worksheet may get a little bit busy. So in this example, I'm going to focus on the count heavy pathway, which is the resident impact and facility capacity pathway. And I will define a surveillance week as Thursday through Wednesday, which means every week I will report new counts collected beginning on Thursday all the way through Wednesday. And that allows me to have 7 full calendar days of new count data. So in this example, as you can see at the top here, the data were collected for Thursday, July 2nd through Wednesday, July 8th. And again, remember, regardless of the reporting frequency into NHSN, only new counts are entered for each surveillance day. So let's say, for example, if I want to enter data for Thursday, July 2nd, I will enter that new count, which I only have for that day, new admissions, and I will not enter that count again for that surveillance week for that same resident. So let's go over a few of these to give you some ideas. So this is my example COVID worksheet that I took from, let's say, a line list. And on Thursday, July 2nd, I had one skilled nursing facility resident with a diagnosis of COVID-19 admitted to my facility. That resident did require transmission-based isolation because symptoms were unresolved. I had no confirmed, suspected, or deaths on this day. So on my worksheet, I'm going to put a 1 for Thursday under new admissions. Then on Friday, July 3rd, I did receive a positive COVID-19 test result for 3 of my residents. So I put under new confirmed, I'm going to put a number 3. 4 residents were put into isolation on this day after developing fever and respiratory symptoms. So I marked those as my suspected, and I put a 4 under suspected. I had no deaths on Friday. Going into Saturday, July 4th, I had 2 additional residents who developed signs and symptoms suggestive of COVID-19, and they were placed on transmission-based precautions. So I put 2 under my new suspected count for Saturday. And then let's go into Sunday, July 5th. I received 1 COVID-19 test result, which was positive for 2, I received positive COVID-19 test results for 2 residents. So you can see under new confirmed, I add those 2. And then I had another resident develop fever and cough, and I placed that resident on transmission-based precautions. So I add the resident under my new suspected count. And then unfortunately on this day, I had 3 residents die. So I'm going to put 3 under my total death count. And then I'm going to look at what was the cause of death for these residents. So one of them was a documented heart attack. And then 2 of them were residents who were already on isolation for COVID, and they died of COVID-related complications. So I will put those 2 under not new COVID-19 deaths. And what I want to stress here is that we have 3 total deaths. So that total death does go under the total death count. And then from that 3, how many were COVID related? So that was only 2. Okay, so the total death count includes all deaths, including those that may be COVID related. But the new COVID death count only includes the deaths related to COVID-19 complications. Moving to Monday, July 6th, I had 3 new admissions, but none of those admissions had a COVID diagnosis or symptoms suggestive of COVID, so they did not go into isolation rooms. So you will notice that I put a 0 for my new admissions for Monday, because new admissions is specific to those admissions that come in with a diagnosis of COVID-19 that require continued isolation. I did have one COVID-19 positive result with one of my residents, so I put 1 under the confirmed, and then I had 5 additional residents that developed signs and symptoms that had to be put on isolation. So I put a 5 under suspected. I had 1 death today, so I put a 1 under the new total deaths, and unfortunately that death was one of my residents who had COVID-19, and it was related to respiratory decline. So that resident also goes under the new COVID-19 death. So as you can see, 1 death is documented in each column with the same resident. Then moving on to Tuesday, July 7th, I received 3 positive COVID-19 test results for this day. I put 3 under the new confirmed. Nothing else happened on Tuesday, thank goodness. So let's go into Wednesday, which is the last day of my defined surveillance week. This was a busy day. I had 1 new admission from a hospital with a resident who had a history of COVID-19 and continued to have ongoing respiratory symptoms. So he was placed on isolation, and I counted him as 1 under a new admission. I then also had another resident who had a new positive test result, which was included under 1 for new confirmed. I did not have any suspected, so no new residents developed signs and symptoms on Wednesday. But I did have 3 additional new deaths on Wednesday. And so I'm going to put 3 under my new total deaths, but only 1 of those deaths was related to COVID-19. So I'm going to just put 1 under the COVID-19 column. Now, if I select to report my data once per week during my surveillance period, then what I would do is I would add each of those 7 days and put it in the bottom column for the week. So you can see here I have my totals for the week, and then I would enter those into the NHSN COVID-19 module after Wednesday. So I could enter Thursday, Friday, or Saturday, or early Sunday, and that would allow these data to be in the report for the CMS submission on Monday morning. Okay, so let's go to the next slide. So now that we talked about an idea of how to collect the data, let's go over very briefly how to enter these data into the NHSN application. So first, you would log in to the SAMS portal, and you would then log in to NHSN, and on your home page, you're going to click the COVID-19 tab on the left, and then once you log in, you're going to, let me back up. So this is your home page. This is what your home page will look like, and I do just want to mention that depending on your access to NHSN, your home page may look a little bit different than this. So in this particular facility, the user has access to all of the modules within NHSN, and that is why you see on the dashboard on the left, you see all of those options. If your user access only allows you access to the COVID-19 module, then you are not going to see all of these other options. However, the way that the COVID-19 module works is the same regardless of your access to the other modules. So we'll go to the next slide. After you click on the COVID-19 tab, this is what's going to populate for you. You're going to see a calendar, and it's going to default to the current month as shown in the screenshot. If you use the forward and back arrows at the top left hand of the calendar, that allows you to enter data retrospectively if you would like to or need to, and then you may enter data all the way up into the present date. So it is from this page that users will either select to enter data manually into the NHSN application, and to do this, the user would select on the reporting date for which data is going to be entered. So in our case, I highlighted here our surveillance week just so that so you could see in the example. You will not see this highlighted in the application. This is just for a training example. So I highlighted our surveillance week, and then you can see I circled July 9th as my date that I'm going to enter the data manually into NHSN. There is another option. If you do not want to enter data manually, you have the option to submit data by uploading a CSV file. So if you look at the bottom of the screen in the left-hand corner, you'll see 3 options there. And the option for uploading the file is the first button, and that allows you to upload your CSV files. We also have CSV templates available, which make your file upload a little bit easier because the template has all of the items, all of the data elements that are needed for the upload, and all that you would have to do is complete each column for submission. With either data submission option, I do want to mention the user will have immediate access to the data. So either once the user enters the data manually and saves a pathway, or all 4 pathways, depending on how a user decides to enter data, that data will immediately show on the calendar. Same thing if a file is uploaded. Once it's uploaded, the user will receive a pop-up message that verifies a successful upload, and then once you click OK, you will also see that pathway completed on your calendar. So let's just take a look. So for the purposes of this training, let's pretend that we are going to enter our count manually into the module. So what we're going to do is click on July 9th. And once we click on July 9th, this is what you're going to see. So next slide, please. A separate window will appear with 4 tabs at the top, and each of those tabs represent the reporting pathway. The selected date from the calendar view page will be available at the top. I have it highlighted so that as a reminder. And the default page, once you get to this screen, is the resident impact and facility capacity pathway. However, users may navigate to and from each pathway during one session to enter data. And data will not be saved, though, until that Save button is selected. So you could navigate through each of the pathways just to take a look, browse around, and click Cancel. And by doing that, nothing is going to be saved. So once you hit Save, that is when the action happens. So if we take a look at our worksheet, and remember I'm entering these data once for the week, I'm just going to take my totals at the bottom, and you can see that I've entered them into the count categories here. So I had 2 admissions, 10 confirmed, 12 suspected, 7 total deaths, and 4 COVID-19 deaths. And just so you know, this is only one portion of this pathway. There's more, but for the sake of time, I just really wanted to show you how to do the count data. When you do your count for the staff and facility, the staff and the personnel impact, you will do your counts the same way as shown for the resident impact. Okay, so let's say that I've entered the data, and I'm going to click Save. Next slide. Once Save is done, you'll have your pop-up message that says, successfully saved the record, and then you're going to notice the record appears, or the pathway appears on that calendar date in which you entered it. A complete record will be green, and then an incomplete record will be highlighted as a tan color. A missing record will just be white space. So you can see for July 9th, I've only entered data for the resident impact and facility capacity pathway. I have not entered anything else. Okay, so let's go to the next slide. For the sake of time, let's fast forward and pretend that we just entered all of our data for all 4 pathways, or we uploaded a CSV file for each of the pathways. And I want to just stress, as was mentioned earlier, that it is important, regardless of how your data are entered, that you do verify complete records. So in this example, you can see that we have one pathway that does have incomplete data. So our supplies and personal protective equipment pathway is showing as incomplete, whereas our other 3 pathways are showing as complete. So to make edits to this pathway, all we have to do is click on the pathway that we want to make edits. So in this case, we're going to click on that supplies and personal protective equipment. Next slide. And then you can see here that we missed one question. I forgot to enter yes or no for NHSN or N95 mask. So all I need to do is correct my error, and I'll just select yes or no here, and then hit save. Once I hit save, if you can see at the very bottom, I get another pop-up just confirming that it was saved, and now you see all 4 pathways are green, which is good. Green is good. Okay, so let's go to the next slide. I want to talk a little bit about how important that it is for data submission to be accurate and timely. Not only is NHSN the platform for shared required data to Centers for Medicare and Medicaid Services, the data collected through this module will also be, or has been used to strengthen COVID-19 surveillance on a local level as well as nationally by monitoring trends in COVID-19 infection rates, including outbreak detection, by assisting in identifying facilities experiencing shortages in staff and or supplies, personal protective equipment, as well as assisting local, state, and federal health authorities to direct resources to nursing homes. Additionally, these data will characterize the national impact of COVID-19 among residents and staff in nursing homes, as well as inform ongoing activities to support our providers. So I want to circle back around before we leave this slide and just remind you about outbreak detection. Just keep in mind that NHSN does not replace any state or local reporting requirements to your public health agency. So NHSN is separate as far as reporting goes, and you'll still need to make sure that you are following your local and state requirements for reporting compliance. Okay, next slide. Just as a summary, be sure to visit the NHSN Long-Term Care Facility COVID-19 Module webpage for access to a wealth of information and resources. We do keep this webpage updated. If you have questions about reporting to NHSN, send those questions to nhsn@cdc.gov. To expedite your submitted question for a more timely response, you can add LTCF in the subject line. And if you really want to speed up things, maybe add a one-word subject. So for example, maybe you add LTCF dash, add a new user, or add new user, or LTCF COVID-19 module questions. Because like I said earlier, we do have different subject matter experts that are assigned depending on the type of question that comes in. And then I think I have the very last slide I'm not going to read to you, but I just put on here some available resources that are available to you. If you have not already taken a look at the COVID-19 Frequently Asked Questions document, please do. It is on our website here, and it is a collection of all of the questions that have come in since the beginning of the module, as well as our responses. And you may find that you don't need to submit a help desk ticket because your response may already be there. You'll also find templates and guidance documents, as well as archived recorded trainings and upcoming trainings. So please bookmark that website. And this concludes my part of the presentation today. Thank you so much for your time, and I will pass the call to Lisa.
Thanks so much, Angela. We appreciate that. we wanted the opportunity to clarify one thing before we continue with our question and answer session, and this would be the July 22nd press release that announced new resources to protect nursing homes against COVID-19. We wanted to provide some clarification that only the scenario-based learning module is going to be tied to the provider relief funds, not the 23 educational topics that are presented and what we're currently on right now on a weekly basis. That module has not been released yet, so please stay tuned. Once all the inner workings are finalized, we will provide information on these calls, in addition through the QIOs and other forms of notification. So we just wanted to let you know that. And in addition, certificates of completion and recognition badges will also be available at a later date, and I promise you we are working on those. So next slide, please. At this time, we would like to conduct an open discussion. Please go ahead and go to the Q&A box at the bottom of your screen and type in any questions that you might have. This is a great time to ask questions on NHSN reporting, as we have the experts right here to provide answers for you. Please remember, we will get to all the comments and questions that we have time to address during the live event, but we'll attend to those unanswered post-event. I would also like to take this opportunity to ask you to please complete the post-event assessment. We value your feedback on how we can improve these in future trainings. The link will be added to the chat box now for you to answer now, and also at the end of the event, it will automatically pop up for you. So we do ask that you fill those out for us. Thank you very much. And let me go ahead and ask our first question today, and this has to do with CDC NSHN data. Do you have any contacts that we can call or send an email to correct the total residents with COVID-19 deaths as percent of confirmed COVID-19 cases? We have sent the information by email, and we have not received anything else. We have several buildings that are showing at 100% death rate when the buildings have no case of death, and another building showing 1,600%, 500%, or 1,000%. And we would like to get the data corrected. We have not been able to get anyone from NHSN that can correct the data and assist to correct it.
Okay, that is a great question. And what it sounds like is that maybe that facility has perhaps maybe a group submitting data for the facility. What we are seeing, and I should have had this on one of my bullet points, is that some facilities that are seeing inflated numbers or incorrect numbers, it is because there is more than one group or user entering data. So it's resulting in duplication. So if you have a group submitting data on your behalf via CSV file, or you have more than one user, it's very, very important that at the end of each week, before the data are submitted to CMS, that you just take a look at your calendar to see what's been reported, because manual data entry will override any data that is submitted via CSV. So that will allow you to correct the data. So what you can try to do is go to the dates in which you have incorrect data, take a look, go to the calendar page, and click on that module and see what is entered in there. And you may find that you have duplication in the actual application. So try that first. I know that we have a team specifically put together to address these issues. So if you want to if you can't get the issue resolved on the calendar page, send another email and put in the subject line Courtney Price. She is our dedicated expert that and she is helping facilities to get these issues resolved.
Thank you, Angela. I believe this next question is going to be from you as well. This question is from LaDonna Vaughn. She asks, if a person is listed under the suspected column and is later tested and found to be positive, do you then list them as new confirmed?
Yes. So if they're put on, if they're included in the suspected number because they, develop new signs and symptoms that cause the resident to be put on transmission-based precautions, then of course that resident gets included in the suspected count. And then later on, if that lab test does come back as a positive, that same resident will also be counted in the confirmed count. That is correct.
Thanks, Angela. We're running out of time, but I have two questions I'm going to merge into one question because they're, I think, very similar. So the one is, in New Mexico, we have been told that reporting once per week on the same day of the week is not 7 days. For instance, if I report on a Monday, then the next week when I enter on a Monday, it is 8 days. Our facility was given a deficiency and fined for reporting our data 1 day late on the 8th day. And the second question has to do with reporting time as well. So does the time of day that we report make a difference? When I report each Monday, it tells me I'm reporting too early, no matter if I report early or late in the day.
That is a great question. And this is the first I've heard of the fine. So we really think it's important that facilities reporting on a weekly basis are including a full 7 days. So if the facility is reporting on the 7th day, well, that day hasn't ended, so you may get additional cases or suspected or admissions throughout the day. So that is why we suggest reporting on that 8th day. I would, I'm not sure who submitted that, but I would really like for you to send an email to me via the NHSN help desk and just put my name in the subject line so we can talk more about that and to see if there's something that our team can help with that deficiency, because it may just be, communication that we need to have with someone. And then was there a second part to that I just missed?
The timing of the day, they report on Monday, and it doesn't matter whether they report early or late. It tells them the time is not okay.
At the time, we do not specify a time. The only thing to remember is that NHSN does transmit the data to CMS. I believe it's right after midnight on Sunday, so it's very, very early on Monday morning. So I would suggest that whatever your surveillance week is, that it not end on a Saturday, that your surveillance week, being Friday being the last day, so that gives you 2 calendar days to get those data entered. So that it can get to CMS. But other than that, we do not, there's not a specific time that you have to do surveillance or reporting.
Okay, thank you, Angela. I think we have time for one more quick question. This one is probably going to be for you again, Angela. She asks, when you get an email to confer rights, what does that mean? Each facility has access and an administrator. Are they not able to confer rights for each facility?
That is a great question. When you get an email to confer rights, that means that someone, it could be your local or state health department or your corporate entity, has set up a group that they would like you to participate in. And what that means by conferring rights is that you are giving rights to that group to see your data. So I suggest whomever's asking you for that you work with that group. If it is the health department, you definitely want to work with the group and discuss a plan. And then again, remember, any group that is reporting data on your behalf, you want to make sure that you have just one group and that it's consistent and they're reporting the data that needs to be reported and no one else is uploading that data, because that's how you end up with duplicate data that gets reported to CMS.
Thank you, Angela. Could we go to the next slide, please? Please join us for the next call in this series on August 13th from 4 to 5 p.m. Eastern Time. The topic will be on transparency, resident and family notification, Department of Health and other notifications. Registration is required, and we will chat in the registration link for your reference, or you can also register for the event or the entire series on the QIO program website, which we will also offer in the chat box. Next slide, please. Thank you again for your participation in today's call. We hope you found some value in the topics discussed. And just as a reminder, please take a moment to complete the survey, and we hope to see you next week. Thank you.
That concludes today's presentation. We will now be disconnecting. Thank you.